back by popular demand, Dr. Sergio Zanotti, our Chief Medical Officer of Critical Care, is here, and we are thrilled to have you back. I'm going to kick it over to you.
Thanks, Annie. So we can show the next slide. And I think in the theme of sharing good news or things that happened this week that were good, I'm sharing our family celebration. So my wife, Leticia, had a birthday this week. And with the help of a lot of her friends, we were able to do a very select celebration with my son, Nicholas, myself, and Leti, with food from her favorite restaurant. Another friend dropped off a wine cooler with drinks. Another friend baked a cake and sent us the candles. We did a Zoom call with our friends, but really had a nice time, and just a reminder, I mean, that life goes on, and really celebrate what's important with our families. And on the right, you can see my dog, Charles de Gaulle, who was very upset at the after party because apparently he didn't get the invite and was not invited to the table. So he was upset when I was doing the plates and cleaning. I saw that he was really, really bothered by not being part of the celebration. So with that, we'll talk on some clinical topics. Today, we're going to talk about comparisons of different face masks, and this is a study that Annie noted in Brecker's review, and I went and looked at the study, and I thought it was useful to share with our colleagues. And then, following our theme of previous virtual villages, I'm going to share with you two topics that were discussed in our recent last Tuesday's clinical webinar, and just share with you, I mean, some of a summary of two of those topics that include COVID-19, the top 5+1, and post-COVID-19 syndrome, which is a topic that Greg Johnson had shared with during our clinical webinar. Next slide, please. So this is actually a very interesting study that was published in Science, Advances in Science, but was picked up by many news media or news outlets. And basically what it is they devised a very low cost method of using light through lasers and a video camera to measure the efficacy of different types of masks that are being utilized by the public and preventing the spread of droplets. So this is really more a proof of concept of how we can be testing these masks as more and more masks come to the public. But also, I think there's two important points. One is that it's really focused on the amount of the ability of the mask to decrease droplets going from the person wearing the mask outside. So it's more about protecting others, which I think is ultimately the real reason why we should all be using masks when we're in public. But it also, I mean, is a small study, but they found some very interesting things, and I think it's worth sharing. So what you see here is the box on the left is basically the device where they use laser and a video camera, and by having people speak in a kind of protocolized way, they can capture the amount of droplets, and they can measure that and give an idea of what the different masks do. So here you have a whole gamut of 14 different masks that include a fitted N95, which is what we use in the ICU when we're dealing with COVID patients, to bandanas and fleece scarves that have been recommended by the CDC and the press as something that can be utilized, surgical mask, cloth mask, and then many other types. So what did they find? Next slide, please. Very interestingly, what they found was that, no surprise, the fitted N95 has the greatest amount of stopping droplets coming out. That's what we use usually in the hospital. It also probably has the greatest ability of stopping any type of airborne coming into your mouth, followed by the surgical. But what's really interesting is when they compare, and you can see all the different types of masks here going from left to right and increasing the amount of relative droplet counts that were captured in the video camera. But what's very interesting is that the bandanas and the fleece were almost as bad, or in the fleece case, worse than not using a mask. And the argument that they're making is that what happened probably with both the bandana and the fleece scarves is that what's happening is that large droplets are being broken up into smaller droplets, and that is what is increasing the droplet count. But it suggests that perhaps encouraging people to use bandanas and fleece is not what we should be doing, and that all these other masks offer significantly better prevention of droplets going out. There's also been a lot of recent studies from also from North. This is from Duke. There's another study from UNC actually where they looked at hospital masks, and what they found is that even re-sterilized N95s or um, even N95s that have expired 10 years are still better than the surgical mask and some of the other devices that people have recommended. So just I think something interesting just to share that not all masks are made equal, and that as we learn more about these, obviously we can make better decisions in terms of what we should be using in terms of helping our society in decreasing the transmission of this virus. Next slide, please. This is what we talked about at our recent COVID webinar. It's COVID-19, the top 5+1 is what we presented. And the idea here was to really take a little bit from humanistic psychology. I'm a big fan of Abrams Maslow work, and a lot of you might have heard of the pyramid of human needs, but he was really focused towards the end of his career in Theory Z, which is about understanding how human beings can transcend and self-actualize. And for most of his initial research in this theory, he focused on peak experiences. And definitely, I mean, peak experiences have an important meaning in our life. And we've heard some of the reflections today our peak experiences in terms of really people going beyond in very extreme circumstances. But what he ultimately found was that it's the plateau experiences, those that we create on a daily basis to give our lives meaning, that are probably much more influential in moving things forward in our lives and moving things forward in terms of making sure that humans can transcend and can really self-actualize. And the reason why I like this analogy is because in critical care, especially in patients with COVID, when we talk about what's called ARDS, we talk a lot about peak inspiratory pressures and plateau pressures. And it's the plateau pressures that ultimately determine how these patients do, and it's something that we follow very closely. So in terms of how do we apply this to what we should be doing for all COVID patients, next slide, please. This is an example here of a peak and a plateau. Peak is I'm using everything that I can find in my hospital, from concoctions that have no evidence like this tent, to an activated PAPR, to triple layers of masking, to double gloving, to putting everything in plastic to prevent COVID. That's a peak, and people were very focused on that. Yet when I'm done with the intubation, I go to the call room and I eat with my colleagues without any mask. And that's where people are getting sick. So what we're trying to do here is determine what are the things that we should be doing in every patient every single time for every single encounter in terms of the plateaus, in terms of making sure that we provide the best care based on the available evidence. Next slide. What we found is that when we review the evidence, there's really 5 things that we should be doing all the time for every single patient. So number 1 is universal masking, and this really means everybody in the hospital should be wearing a mask and every patient in the hospital should be masked. Respiratory management, the use of what we call lung protective ventilation, which is something that we've been using for decades now in ARDS. And despite all the enthusiasm with new descriptions, with new ideas, we should stick to what we know works in patients who have similar diseases from other causes in terms of when they get on the ventilator. In terms of the inflammatory response modulation, the one therapy that has shown to improve outcomes of those patients, improve mortality in those patients who have COVID-19 and require oxygen or mechanical ventilation, is the use of a corticosteroid called dexamethasone. So we should make sure that all our patients who are on oxygen or mechanical ventilation are treated with dexamethasone 6 milligrams for 10 days. And that has been shown in a very large clinical trial to decrease the likelihood of the patient dying. If you treat 8 patients with dexamethasone who are on mechanical ventilation, you will save 1 life. If you treat 25 patients who are on oxygen with dexamethasone and COVID, you will save 1 life. Those are very powerful numbers, and I think it's upon us as clinicians to make sure that our patients are getting that. Number 4 is antiviral therapy. And here we don't have as robust evidence as with dexamethasone, but clearly the data that we have as of now suggests that those patients who get remdesivir, which is an antiviral that was developed for Ebola, didn't work for Ebola, but seems to have some positive effects in COVID. They can decrease the time to recovery in patients who are in the hospital. So where available, where applicable, the use of remdesivir. And finally, it's the use of adjunctive therapy such as prophylaxis for people forming clot, what we call antithrombotic therapy, that again should be given to all patients who are hospitalized. Now, these are all interventions that are really focused on the hospitalized patients, but obviously a great number of our patients are hospitalized in our hospital medicine and critical care lanes. So we wanted to make sure that everybody is aware of these are the 5 things that we expect based on the level of evidence every single patient should be receiving in our practice. Next. And finally, I wanted to share, and the plus one, which I think is not based on randomized trials, but really based on what we have seen from a human perspective, is with families unable to be at the hospital, we need to make sure that every one of our practices has a process to enhance and optimize family communication, that we have appropriate goals of care discussions, and that we find ways to provide not only a good death, but to connect families to their loved ones who are in the ICU, who are in the hospital. And this is just a low-tech use of something like FaceTime. But many hospitals now have actually implemented Zoom calls, regular Zoom calls for patients in the ICU, have deployed iPads so they can communicate with the patients can be seen by their families. And I think that having a deliberate effort of improving communication in such difficult times is, I think, a must for us and needed more than ever. So finally, next slide, I wanted to share with you a little bit about what we talked about at the clinical webinar, and Greg Johnson presented this. Can we move to the next slide? There you go. Is the post-COVID syndrome. And you probably might hear a lot of this in the lay press, but also in the clinical literature in the last couple of months, there's been over 800 publications if you look under post-COVID syndrome or post-COVID symptoms. And just a realization that yes, this is an acute disease, but that there might be lingering healthcare effects on patients for a long time. And that time frame might be more pronounced in those patients who have the sickest forms of COVID, those that require to be in the ICU. Next slide. This is a slide that you may have seen before. I think Nate Ruck showed. It's from a study in a 143 hospitalized patients in Italy. And basically what you have here is on the right, on the left, you have the acute phase of COVID and the symptoms that these patients presented measured as a percent. And as you see, fatigue, dyspnea, joint pain, chest pain, cough were all very common. And then what you see in the follow-up on the right, which occurred up to 60 days after the patients were discharged from the hospital, there was still a significant amount of symptoms, next slide, that included fatigue, dyspnea, joint pain, and chest pain, cough, and the loss of smell, which is anosmia. So basically, even for weeks after, these hospitalized patients had significant symptoms still persistent. Now, we still don't know a lot about what happens to patients post-COVID. Several of our colleagues, both clinical and non-clinical, either who have had COVID or had family members who have COVID, have reached out to me and asked me about this. I have shared this study with some of our colleagues who reached out. But the reality is that anywhere from 6% in some studies to 10% in other studies to much higher percent, 40% in those who are in the ICU, of patients who have an acute COVID disease will have symptoms persisting for weeks afterwards. Next slide. We have learned a lot about prolonged symptoms in critically ill patients and those patients who are in the ICU for sepsis, which is a severe infection, which COVID is a subset of sepsis. And a lot of people have studied this post-ICU or post-sepsis syndrome, recognizing that in these critically ill patients, when you follow up on them 3 to 6 months later, a third of them might have PTSD, a third of them might have depression, a third of them might have cognitive dysfunction. Only 50% of them actually get back to work at 6 to 12 months. So really, I mean, the impact of critical illness such as septic shock and ARDS is devastating on our patients, and we're probably going to see similar things with COVID in those patients who are sick enough to be in the ICU, to be on a ventilator. So these are things that are encouraged for interventions that have been studied in severe sepsis and sepsis in the ICU that can help patients navigate that post ICU syndrome that we think would also be helpful for COVID. And I think if you have a family member or if you're a clinician, making sure that we're optimizing medications, making sure that nothing fell off, that we take things that they don't need, a structured exercise program, very important, getting people back to their physical capacity, goals of care discussion and palliation, which means treating symptoms is very important. And then obviously peer support in terms of connecting people with people who've had similar disease or families who've gone through the same thing is going to be very important. So these are some of the topics that we wanted to share uh, with our virtual village today. Like I said, I think the one on face mask I think is very interesting. The other two are from our clinical webinar, and like Annie said, we'll have plenty of time at the end for questions. I'm once again, always in awe and very thankful for the amazing work that everybody in Sound is doing at the front lines, at the bedside, supporting our patients, and in the offices, which are now home, in terms of supporting our clinicians. So thank you, and like Andy said, we're all in this together, and I think that we will get through it and learn a lot from it. Thank you, Annie.
Thank you, Sergio. As always, we're in awe of you and all the information you share with us. And it's amazing how far we've come, frankly, in terms of learning about COVID, something we've never seen before.